So the next speakers, Dr. Dimut Gunasekara is going to speak on SLT is a good option in glaucoma, and Dr. Dilini Udayangani going to speak that medication is a better option. So I would like to invite Dimut to the stage.
Thank you for the invitation. Let me start with defining my topic. So I'm for SLT, selective laser trabeculoplasty, instead of medication in the management of glaucoma. So what are the definitions? So glaucoma. Glaucoma is a chronic progressive optic neuropathy characterized by excavation appearance of the optic disc, often described as cup, together with loss of retinal ganglion cells and their axons with corresponding visual field loss. And intraocular pressure is the only modifiable risk factor. And I have underlined it's a chronic progressive disease. If we define glaucoma medications, there should be chemical compounds that should address the glaucoma, which is a chronic progressive disease. So it should be a drug that should be used for a prolonged period of time. So that is one of my arguments. Then what is selective laser trabeculoplasty? If I take it as a nutshell, it is delivered via a laser machine. It is lithium aluminum garnet laser, which is applied over the patient's trabecular meshwork via a gonio lens. So these are the settings. So you can see, if you see, it is Q switched 3 nanosecond pulse frequency doubled YAG laser. And if you see the energy, it is very low energy. It's in millijoules, but in current SLT machines, it's in microjoules as well. So it's very low energy compared to argon laser trabeculoplasty, which is used previously, which causes disruption of the trabecular meshwork. But here, it is my next important point is that it causes a physiological, functional change in the trabecular meshwork by exposure to the pigmented cells of the trabecular meshwork. It causes cytokine macrophage response, which causes physiological clearance, enhanced clearance and rejuvenalization of the trabecular meshwork, whereby addresses the main pathological process which causes elevated intraocular pressure in glaucoma. So then what are the problems with drops? So first thing, it's cost. Then it's side effects. So side effects could be local or systemic. Then patient's forgetfulness causing inability to put the drops. Then comorbidities like dry eye, then difficulty in putting drops, causes poor compliance, which results in fluctuation of IOPs. Fluctuation of IOP is the major cause for glaucoma progression. Another thing is the side effects, the tearing, burning, pain, redness, photophobia, fluctuation of vision. Because of all those things, patients tend to default from medications. And it has been shown by evidence-based medicine that detrimental effect of preservatives in eye drops, like due to these symptoms, side effects, patients tend to not to put the drop. And you can see in the slide, one of the local side effects of prostaglandin analogs, the prostaglandin-associated periobitopathy, where there is in the left eye of the upper left corner, if you can see, the patient has put the prostaglandin analog to left eye, so there is periorbital fat necrosis, fat atrophy. And in the right side, you can see the patient has put the prostaglandin to left eye, where it caused the periorbital fat necrosis with hyperpigmentation, causing disfigurement. And this is hypersensitivity to alphagon, causing blepharodermatitis. So what are the other problems? Preservatives. So drugs contains benzalkonium chloride, which can cause disruption of the globular cells, meibomian glands, and causing trabeculitis and atrophy of the Schlemm's canal and distal channels, leading to worsening of glaucoma in prolonged use. Other thing is it causes challenge survival of the trabecular meshwork and ocular toxicity resulting in subconjunctival fibrosis, which causes difficulty, or it makes it difficult for the further filtration surgeries in the future. So then what are the points, what are the advantages of SLT? So if we compare the SLT with drugs, so it takes away the compliance issue. Once patient had SLT, so it has been applied over the trabecular meshwork, 180 degree or 360 degree, whatever the dose the surgeon wants, the effect is there, lasting longer, more than 5 years. And it can reduce the amount of drug, decrease the IOP fluctuation, lesser toxicity to ocular surface, cost effectiveness, reduce office visits, better quality of life, repeatability, because we can repeat SLT more than one time, and can be used safely during pregnancy and breastfeeding. So SLT as the first line therapy for the management of glaucoma. If we consider SLT as the first line therapy rather than the drugs, now the current trend is using SLT as the first line therapy because it causes IOP reduction with visual field stability, optic nerve stability, and it improves the quality of life. So another thing is if it's efficacious. You can see the study in selective laser trabeculoplasty as initial treatment, which causes similar effect to the prostaglandin analogs, that is 30% reduction over 1 year. And in this study, it's 31% reduction over 5 years. And the famous LIGHT trial, which is randomized double-blind control trial, which caused cost effectiveness and effectiveness for more than 30% up to 6 years.
Thank you, Dimut. Your time is over now. Thank you for the speech. And next, I would like to invite Dr. Dilin.
Good afternoon, everyone. Our topic is SLT versus medication in glaucoma, and I'm talking for medical management. So basically, medical management, whatever the treatment modality, the main aim is to preserve visual function by lowering IOP. As ophthalmologist, that's our duty. So in medical management, it is mentioned as the long-term efficacy of treatment is judged by the stability of the visual field, optic nerve, and other structural parameters, and assessed regularly by ensuring adequate IOP reduction. So versus SLT, so what are the advantages in medical management? So we have multiple modalities. Dr. Dimuthu talked about SLT, which only addresses this outflow facility pathway. But we have several options in medical management where we have prostaglandin analogs, which addresses the aqueous humor outflow via the ovoscleral pathway and decrease outflow resistance, beta blockers that reduces aqueous humor production, carbonic anhydrase inhibitors again reduce aqueous humor production, and parasympathetic agents improving outflow facility, and the newer agents, rho kinase inhibitors, relax the cytoskeleton and increase the trabecular meshwork outflow, and also hypoosmotic agents. So SLT reduces IOP by increasing outflow facility only. And when we talk about the efficacy, these are proven percentages of efficacy in the medical management of glaucoma. And so they are in the range of mostly the 20 to 30% range. And so the SLT efficacy, the problem is that it has been mentioned that efficacy reduces with time. So 1 year, 68%, 2 years, 46%, and 3 years, 32%. And it needs retreatment. In the LIGHT trial, patients who were not at target IOP after a single SLT received another treatment of 360 SLT at the same energy setting with re-evaluation after 2 weeks. So you can't be sure that with one go that it will reduce the IOP, so that you need to monitor the patient. So based on their clinical experience, the NICE committee further noted that any effect from SLT might be reduced after repeating the procedure more than 2 or 3 times. That's how far that SLT can go. So therefore, even after that, the medical management will come into play. So now the topic says glaucoma. So medical management is not only for primary open angle glaucoma. So the recommendation in the NICE guideline says newly diagnosed ocular hypertension with IOP more than 24 or more, or newly diagnosed chronic open angle glaucoma. Those are the only indications for SLT. But glaucoma is more than that. Glaucoma, we can use medical management for almost all types of glaucoma. Even in angle closure, for initial IOP control, we need medical management. So, and it was also mentioned in the NICE, the recommendations that specially mentioned pigment dispersion, that the SLT should not be used, and there was not enough people in the pseudoexfoliation group to recommend it as a primary therapy. And also it says that no evidence was identified in people with advanced chronic open angle glaucoma, as the light trial excluded people with advanced glaucoma. So if I say like, now the medical management, the efficacy of medical management is like age old. So these are quite old trials, but I could find a review article which, so if you say now, then Dimuthu can argue saying that SLT is talking about primary open angle glaucoma. So I'm telling that for primary open angle glaucoma, the medical management, this review article shows that all these drug classes are very efficacious in statistically proven efficacies, therefore, even in primary open angle glaucoma. And also combination drugs are also effective at second line. So the NICE guidelines in 2022, which is a updated version, they clearly mention that high quality evidence showed that there is no meaningful difference between 360-degree SLT and eye drops in achieving a target IOP, health-related quality of life, risk of total adverse events, and treatment adherence. So these are the trials they have chosen in the sense that they have included and excluded certain criteria, and these are the landmark trials they have selected in making the recommendation. So here there is a comparison with SLT versus eye drop, the outcome taken as the intraocular pressure. You can see in the right hand side, this old study shows that there's no meaningful difference. And this is the quality of life evidence that they have selected, and there's no meaningful difference in all of these. So why they have recommended SLT as the first line treatment? So mainly on the cost effectiveness. So can we do without eye drops? No, we can't do. So if they have to, if the IOP is not controlling, we have to go for medical management again. And then we have multiple choices to select from, multiple categories of drugs and multiple drugs in each category. So administration is by the patient. So you need an expert to perform the SLT and need support and have relevant training, and it is mentioned in the light trial. An expert has to train the trainees and also to observe at least once the SLT is being performed by an ophthalmologist. What about acute situations? This is only newly diagnosed open angle glaucoma and ocular hypertension, but we get acute situations. So we need medical management to tackle the acute situations such as carbonic anhydrase inhibitors, oral carbonic anhydrase inhibitors, which act within 15 minutes.
Thank you, Dilini. So thank you very much, the speakers. So I will move into the panelists. First, Dr. Prasad. You are an expert in SLT, I think. You do a lot SLT. What's your opinion? What do you do in your practice?
Actually, both speakers spoke very well and in detail. But as you know, both treatment methods are evolving. Actually, now in Sri Lanka, what we are practicing is not the initial SLT, conventional SLT, but some advanced SLT, that multi-spot laser. Actually, the normal conventional SLT, we use relatively high power, but it's only 1% of the power that we are using now. So the damage and everything is much less. And when you think about the medical management, it has also evolved. Now, earlier, our main aim is to reduce the pressure, control the pressure, but newer treatment methods like Rho kinase inhibitors, it address both ganglion cell saving and optic nerve head blood supply and neuroregeneration, and all the aspects are covered with newer drugs. Now, they are not available, but it's used in Japan and USA. Rho kinase inhibitors, I think we'll get it very soon. So the medical management as well as the SLT, we need both for management of patients. As Dimuthu said, actually it's regarding compliance issue. The SLT look up the patient very well, even if they are not compliant and ignorant, because once you do SLT, it lasts for nearly 3 to 5 years, and you can repeat as many times as you wish. And the one more thing I have to correct, because only the angle closure glaucoma where the trabecular meshwork is not visible, you can't do SLT, but all the other patients you can do SLT, even pigmentary glaucoma, pseudoexfoliation, and all the patients you can do SLT. And it has some effect, but you need some support from the medical management to control the pressure properly.
Thank you very much. So as a first line, you use SLT sometimes here. What about your practice, Gan?
Thank you. Yeah, as Dr. Prasad mentioned, both speakers presented well. To speak about this two speeches, I feel Dimuthu, the speaker who talked about the SLT, who talked for SLT, could have talk more about SLT, could have talked more about SLT instead of, you talked first about disadvantage of the drop, and then you missed a little bit about talking more about SLT. And Dilini, and you in Dilini's speech, you mentioned some contraindications quoting NICE guidelines. So pigment dispersion, so you mentioned anger as the indication for SLT is only the ocular hypertension and the open angle glaucoma. It's not. You can use SLT in almost all kind of glaucomas, even in advanced. Usually you use it in mild to moderate glaucoma, true. But it is a useful tool for even for advanced glaucoma till you do the surgery. It's an adjunctive, and it's a useful tool to get the IOP down. It may be not meaningful IOP reduction in advanced glaucoma, but you can buy time with SLT. And you mentioned about pigment dispersion syndrome as a contraindication. It's not. You can, it's a relative contraindication, but you can lower the settings and still use, you can get good results in pigment dispersion as well. Uveitis glaucoma is a contraindication, yes, but pigment dispersion syndrome and advanced glaucoma are not contraindications. You can still use it. You have to adjust the settings. Yeah, the cost is a huge. The cost is the main thing when it comes to drops. So if it's available, SLT is cost effective, and quality of life also it improves. Yeah, so SLT, if available, it's a good choice in my opinion as a first line treatment.
So how do you manage patients? Like you start with medications first, then if it is not controlled, do SLT. What sort of a thing you do?
So when it comes to, I give the choice to the patient. Sometimes when you mention the term laser, they get hesitate. So, but this is not a conventional laser type. When it's laser, they have an idea about the laser like a painful procedure, but this is not a painful procedure. This is one of the most gentle laser procedures available. It tickles the trabecular meshwork with very little energy. So, most of the time, I give the choice to the patients. If I mean both types are equally effective. In my opinion, my personal opinion, SLT, it's has less hassle and more compliance-wise more effective. So if the patient is willing to get it done, better to get it done.
So you agree on this?
Yes, I do.
Yes, actually, I agree. The thing is, the availability of the laser is the problem. When it's available, actually, first-line treatment, if I get glaucoma, actually, I prefer SLT first because it's just restorative, not destructive. And it's a physiological mechanism that you stimulates. And in the other way around, newer drugs, when it comes, actually it's different because it's not only control the pressure, but it saves the optic nerve head.